about to experience Healthline, a show where doctors from Makati Med interact with you for a healthy, uplifting lifestyle. Moderated by Nicole Jacinto. You've got questions, we've got answers. So welcome to Healthline.
Hi, welcome to Healthline with Makati Med. I'm your host, Nicole Jacinto. And on today's program, we're going to talk about chronic kidney disease. With us today, we have Dr. Michelle and 𝗛𝗲𝗹𝗁, MD. I know when I'm getting older because the doctors are younger than I am. I'm quite sure Dr. 𝗛𝗲𝗹𝗁 is younger than I am, but I can tell from just having spoken to her a bit right before the show that she is very capable and that she has enough experience and intelligence. So if you ever get to her as a doctor in Makati Med, of course, then I think I can judge that you are in good hands. How are you today, Dr. 𝗛𝗲𝗹𝗁?
Oh, very fine. Thank you for having me here. Thank you for the invitation.
Yes, thank you for accepting the invitation, and thank you for sharing your time, your effort, and your knowledge with us. It's not just me who's interested in these topics, but the people who watch us. And having said that, by the way, I'd like to say, I'd like to give a shout out to Oma Alberto, who loves the show. And I hope she's doing well right now. I hear she's doing well. And also, I'd like to, it is Monday, April 3, 2023, completo indeed, doctor. I'd like to say happy birthday to my sister, Bea, my eldest sister, who looks younger and much better than I do. But anyway, happy birthday, and I love you. Okay, Dr. Alberto Zaite, we're here to talk about chronic kidney disease. But before we go into it kind of in depth, can I ask you just like some basic questions? What are the kidneys' functions in the body? First of all, we have two, right?
Yes, normally, if you're blessed with two kidneys, you will have two kidneys. So they are actually kidney-shaped, kidney bean-shaped organs, no? So it's found at either side of our spine, in the middle of our back. So it's deep in the abdomen, no? So what they do is they are the excretory department in our human body. So they filter out the wastes, the toxins, no? In the form of urine that gets passed out of our body. So aside from that, they also are in charge for balancing nutrients, fluids, electrolytes, acid base, no, in our system. They are also in charge of releasing some hormones that may affect our blood pressure, also the bone health in our system, and anemia or control of red cell production. So there are a lot of things that the kidneys can do for us. No? So it's very important that we keep them healthy.
It's particularly interesting to me how you said normally we are born with two
normally, yes.
Because my grandmother was born with one kidney. So that's like a family, that's part of the family history that we all know. So I'm glad you said that. Because some people may be born with one kidney.
Yes. Okay. And they can still live normally, actually, with just one kidney. But when you're born with one kidney only, you may be at risk for other conditions later on when you get older.
Okay, so just to go there a little bit, no? If you're born with one kidney, yes, you can still live normally, and as you said, you may be at risk for other conditions. Is that because some people say that that you only actually use one kidney, but is that true, or do you use both? Is there a balance?
Use both. You use both. Yes. No. I said that because the function of our kidneys really depend on the number of nephrons. Okay, so that's a technical term.
Yes.
So nephron is the functional unit of our kidneys. So for example, each kidney has, say, 1 million nephrons, each of them. And if you are born with just one kidney, you're with half of the usual. Okay. So it's very important when we discuss later on about chronic kidney disease, the implications of the nephron number or how much functioning nephrons you have left, no? Surviving nephrons in the care of patients with CKD.
Okay. And that's why your specialty is called nephrology.
Yes,
Yes.
nephrology.
So when you hear, just to remind people out there, if your doctor says, let's say your general practitioner says, I'm gonna recommend you refer you to a nephrologist, that's someone who specializes in the kidneys, someone like yourself. All right. So we've heard about some nephrons. You mentioned earlier, just to recap a bit, that kidneys are responsible, they're part of the excretory system. So that means they they excrete, no, from your body. So they filter waste.
Yes.
Is that from your blood or any other part of?
Yes.
Okay.
So from all of the other organs, your normal processes, the foodstuffs that we take in, no, they get metabolized in our systems. And the blood gets filtered. About 20% of our cardiac output goes to the kidneys. And there's a mechanism by which the kidneys retain, filter out the wastes and then retain what we need. And what gets left is the product which is in the urine. So that gets excreted out of our bodies.
Okay. And they are also important. I know I only learned this like a few years ago, that the kidneys play a lot in terms of regulating blood pressure. And you mentioned earlier that they release hormones also that help regulate blood pressure. So it's not just a function of getting rid of waste in the form of urine, but helping to regulate blood pressure and
electrolytes.
Okay.
Yes, salt content within the body.
Also, no? I mean, you have to have a good electrolyte balance for your
for the heart, and all of the rest of the organs also.
One of the reasons why I wanted to point that out was because a lot of people will have been wondering, just how come if I start having high blood pressure, I have to also watch my kidneys later on. So these are things that are related, but of course, we can talk so much about the kidneys, and I hope that you do come back and talk more about it. But we're gonna try to sort of go down the line and focus on chronic kidney disease in just a bit. So I guess if you could just answer very briefly as a doctor, why is renal care important, or why is it important to take care of our kidneys?
Well, of course, having kidney disease will be a large burden to the person, not just the person, the family, and the society, of course. And renal care is important because we want to prevent those at risk to have CKD. Okay, and those who have already CKD, we want to slow the progression of CKD.
Okay.
And address the complications if they are already in the advanced stages.
We know now that there are tests for kidney function, which we didn't really do before. I mean, like many years ago, we didn't, we just, let's say, would take a urine test and then we check for other purposes. But are there other tests to test your kidney function?
Yes. So if we're talking about screening.
Yes, screening.
Okay. So first, we have to identify those patients or individuals who are at risk. Okay. So there are a lot of clinical risk factors for chronic kidney disease. And you mentioned a while ago, one of them, that's hypertension and diabetes. So those are the two most common causes of CKD, in the world, in the country, in the country also, no?
Yes.
If you have a history of cardiovascular disease or even a family history of chronic kidney disease. So those risk factors would put you at the high risk for having CKD in the future. And so you have to test them, screen them. So by taking a blood test, so creatinine, serum creatinine, and based on that, we compute our GFR, or glomerular filtration rate. So another technical term, but it just means that it's how much your kidneys filter or filter out the waste products in your body. Okay, and another one is a urine test, which is a dipstick test, or what we call a UACR, urine albumin creatinine ratio, to check for albuminuria. So albuminuria is just albumin in the urine, which is not supposed to be there in large amounts. Okay. So if you check positive for albuminuria, or if your eGFR, or if your estimated glomerular filtration rate is low, less than 60, so you are likely to be a candidate for CKD, because CKD has a definition that has to be persistent for at least 3 months. So you'd have to be rechecked for the span of that 3 months if the albuminuria or the elevated creatinine or low GFR persists. And that's how you get diagnosed. If you do get tested, but for example, you had negative results, then you can be screened annually since you have these risk factors.
Okay, so an annual screening will do, and it requires a blood test and a
Blood
urine
test. Yes.
So the blood test, I have actually done that. I said, okay, let's just check off GFR for, to see what it is. And I do want to say that, and please jump in and correct me if I'm wrong, no? For the GFR, you don't need to fast, right?
No.
No, but
not like the sugar tests or the cholesterol tests. Yeah.
You don't need to fast, but maybe usually they will group it with a bunch of other tests where you do need to fast. Okay, but just to be clear, for those of you who want to get your kidney function checked with the eGFR, you don't need to fast. And also,
non-fasting.
But for the albumin, you also don't need to fast.
No.
It gets grouped in with the other tests because you just want to take your blood test once.
Correct.
You don't like to keep going back and saying, okay, prick me again. Okay, tomorrow prick my blood. So yeah, that's the reason why it's more efficient.
Yes.
But just to make it clear, if you need that test, don't freak out. You don't have to fast. Unless a lot of people are into fasting now. Well, it is for Catholics, it's Holy Week is here, and for Muslims also it's Ramadan. But you don't have to get your GFR now. Just saying, you don't need to fast. I get that question a lot. Like, do you think I need to fast? I'm like, no, I'm pretty sure you don't have to. That is from being a frequent patient, and not because I'm and the doctor like you. Okay, so doctor, you've answered some questions for us and gone to some of the heart of our discussion in terms of how do you get screened for it. But I'd like to take a short break if that's okay with you.
Sure.
And when we come back, let's talk more about, let's get to it, describe chronic kidney disease. Okay, so let's take a short break. Everybody stay tuned to Healthline with Makati Med. Coming at you from Metro Manila, from different parts of, are you in Metro Manila? Don't answer that, you don't have to. Okay, we're coming at you from different locations through the use of technology on DZRJ 8:10 a.m. Radyo Bandido. And of course, you may be viewing us on our TV channel, on our Teleradyo TV channel, or on Facebook Live, or on you can always click on the show and watch again through our other TV channels, and also through YouTube and other platforms. So we'll be right back. Stay tuned to Healthline with Makati Med.
You're listening to DZRJ 8:10 a.m. We'll be right back after these reminders.
Hi, this is Dr. Jacinto and welcome to Makati Med Wellness Center. Located at Ayala North Exchange, the Makati Med Wellness Center is a warm and comfortable state-of-the-art lifestyle center where executive checkups and services that address holistic patient care and wellness can be done. We have a skin and laser hub, diagnostic imaging, health screening, mind and wellness care, and physical medicine and rehabilitation. The Wellness Center is equipped with modern facilities and staffed with competent healthcare professionals who are committed to deliver premium, personalized, and easy access healthcare services for both adult and pediatric patients alike. This is a great place to prioritize your health and well-being without having to be at the hospital setting. We are open from Monday to Saturday at 7 a.m. to 5 p.m. at the 7th floor of Ayala North Exchange, Tower 1 in Makati City. It is also accessible from the Makati Med Hospital through a bridgeway to Ayala North Exchange. For inquiries, you may reach us at these numbers. We look forward to serving you here at 𝗛𝗵𝗵𝗶 Wellness Center.
You're back with Healthline, keeping you healthy, moderated by Nicole Jacinto.
Hey, welcome back to Healthline with 𝗛𝗵𝗵𝗶. I'm your host, Nicole Jacinto. With us is Dr. Michelle Ann 𝗛𝗲𝗶𝗁𝗍𝗔. She is a nephrology specialist or a nephrologist. Is it okay to call you that? Correct term?
Correct term.
Correct terms there? Okay. Doctor, we're talking about chronic kidney disease. And just to recap what you said earlier, I asked you how the kidney functions, and you said, well, it's more than just, it's part of the excretory system. So it filters waste from your body, and it comes out in the form of urine. And it also has other functions like releasing
Hormones.
Yes, thank you. Hormones that help regulate your blood pressure. And there's also a bunch of other things that it does. And you mentioned the topic of nephrons, but you can get into that anytime you'd like. No, you were talking about if you're born with a certain amount of nephrons and how many nephrons have to be functioning, and this plays into chronic kidney disease. But whenever you feel like jumping into that, go ahead. But first, like for people like me who don't know, who are not specialists like yourself or who don't know much about it, I'm sure there are people there right now who have chronic kidney disease or who have relatives who have it or who are worried, actually worried about someone. Yes, I'm worried about someone right now. Okay. But can you tell us more about chronic kidney disease and like, what is it exactly?
Okay. So you're right. No, a lot of people may have chronic kidney disease and they may not know it. So actually in the statistics, 1 out of 10 adults worldwide have CKD. So that's a big number. So CKD or chronic kidney disease just means that your kidneys are damaged and they cannot filter blood the way that they should. So the disease is called chronic because the damage to your kidneys happens slowly over a long period of time. And the damage can cause wastes to actually build up in your system or in your body. And that causes health problems. So technically speaking, CKD is an abnormality of kidney structure or function. And as I said earlier, present for about 3 months or more than 3 months. And it is progressive loss in kidney function over a period of months to years. So that's CKD in a nutshell.
Yes, that's CKD in a nutshell. And okay, you said it's either damage the kidney structure or just the function. When you talk about damage to the structure, I mean, okay, it simply means that your kidneys are not functioning the way they should and filtering enough waste from the blood, and some of this can go out to the rest of your body. Can it cause sepsis or no, just other conditions?
Well, you may be at risk for infections because CKD may make you immunocompromised.
Okay. Okay, so it could be, and there are other things also. Okay, so it can affect your immune system as well.
Can affect your immune system, can affect your heart, your brain, your muscle, your nerves. Generally, anything that is bathed by the milieu of blood, if toxins get accumulated in the blood, and of course, the organ systems need a healthy environment so that they can work properly. And if that environment is ill or sick or poisoned, they won't be able to function the way they should.
And we pretty much know that blood goes everywhere in the body.
Yes. So let me give you an analogy. Okay. If you've noticed, for example, There was a time in our neighborhood that the garbage collector didn't really come as regularly as they should.
Yes.
Okay, so they used to come like every Saturday, for example, but there was a month wherein they did not really pick up the trash for like for a month or 2 months. So you would see the streets would get piled up with garbage. And what's the effect in the community, you know? What's the effect in the environment? The people would see the trash. It's unsightly, number one. It causes health problems. Okay, it's very dirty. So it causes anxiety within the neighborhood. Okay, so there's a lot of many different effects when you relate that to your body. When the body creates wastes, okay, but the wastes don't really get to be disposed of regularly out of your system. Yes. So I think that's how chronic disease, in an analogy.
Yes, that's a great analogy. I mean, that is a great analogy, doctor. I think we can all understand that. Okay, it piles up. It causes more than, first there's anxiety, then you see the flies going there. Then and it causes health problems. I mean, you could have a fly get on a piece of feces, and then there you go. Then you have this and that and all of these other things. And then there's less pathway for the cars, because you will. Okay, so I don't even got don't put your trash in my space. No, but it's true. Okay, thank you, doctor. That is a great analogy when it comes to CKD, or chronic kidney disease. One of the things I wanted to ask you: are there certain conditions? Well, what are the causes basically of the condition? Before I ask you about, like, can having high blood pressure cause it?
Yeah.
Or what are all of the causes of CKD?
Correct. So a while ago, when we were talking about screening, I mentioned if you have high blood pressure, if you have diabetes, you have to get screened, because actually these are the common causes of the condition. So diabetes, high blood pressure, that's the most common, the top two. Okay. Other conditions would be when you have inflammation within the kidney itself, whether it's in the filtering units, okay, in the glomerulus, or within the tubules and its surrounding structures. So we call that technically terms like glomerulonephritis or interstitial nephritis. No, you can also have like
basta there's an
inflammation.
Inflammation.
Itis is inflammation, like arthritis, diba? Inflammation in the joints. Yes. So other causes would be some genetic or inherited kidney disease, like polycystic kidney disease, or if you have even obstruction in your urinary tract. No, so if the urine or the urine can't really pass out properly, it gets clogged within the tubes in the ureters or down the bladder, etc. So you can have CKD when you have prolonged obstruction of the urinary tract. Okay, also, if you have recurrent infection, also because of that. No, so if you have recurrent pyelonephritis, that's infection within the kidneys itself. So you can have CKD because of that.
Okay, so you could have infections in your kidneys that can lead to this. Let me just recap. And then also high blood pressure and diabetes are one of the top, are the top two other illnesses or conditions that can bring about chronic kidney disease. And of course, you mentioned a lot of let's say areas within our kidneys itself, within the kidney, but infections like that can occur from how could they occur? And you also mentioned even the urethra, or let's say getting UTIs often. Can that somehow back up?
So yes, if you have cystitis often, or UTI, what we call, sometimes the infection gets higher up into the kidneys, and that causes also chronic inflammation and scarring if it's recurrent. Recurrent meaning it occurs every so often. So the scarring, the inflammation, the repeat cycles of that would eventually lead to CKD, because the damage within the nephrons that we talked about earlier.
Yes.
So if you have, let's say, 100% of nephrons functioning at the start, Okay, so we're now going into the pathophysiology of
Okay.
CKD.
We're going, okay.
Okay, so if you have 100% say nephrons at the start, and if you say have like a recurrent infection in a kidney, and let's say 50% of the nephrons get damaged, no, and then just about 30% of them recover. Okay, and then the remaining functioning nephrons really take up the bulk of the work.
Okay. So
Okay, so yes, so later on, when it happens again, the cycle goes on, another percentage of, let's say, surviving nephrons get damaged, and some of them may recover, some of them may not, until the cycle reaches a point wherein there are just a few remaining nephrons and they tire out somehow.
Yes. Okay.
Because of the work, because the work is the same, but your workers are fewer.
Yes. Okay. So so just to recap what you said, you're basically, there are nephrons in your kidneys, and then whenever there's an infection or damage, there's a certain number
Of whatever cause. Of
whatever cause. No, whatever
Yes.
cause it is. I mean, like, for example, could it be caused by a beating?
Maybe, yes, trauma.
Okay.
Trauma, or even intake of some over-the-counter
Medicines?
painkillers, medicines that
Okay.
are, so it causes inflammation within the kidney. So anyway, repeated damage, and then not all of them would recover. No, that's what we call acute kidney injury. Repeated acute kidney injury causes chronic kidney disease in the long run, no? But when you have chronic diseases like diabetes, hypertension, no, all of those really affect the kidneys in its entirety. So,
and it's ongoing, di
and
ba?
it's ongoing because these are chronic conditions as well. So high blood sugar, high blood pressure exposes your nephrons to not to a very difficult environment. So yeah.
Sorry, doctor, go ahead.
Sure.
I didn't interrupt you.
So maybe the capacity of some nephrons will actually, at the start, no, they will hyperfiltrate, or they will try to cope up, but later on they will eventually tire out.
Okay. So yeah. Okay. So basically, doctor, what you're telling me, as someone who is trying to understand this fully, and to maybe some of the audience out there, is, I mean, you're explaining it very clearly. So I just want to check with you if I got it. The kidneys have nephrons, and these nephrons, when they're exposed to injury or anything that causes an infection, there's a certain number of them. Like, let's say there are 100, and some of them can get injured and maybe die off or not be able to function anymore. So the more this happens, the 50 that are left, or the 80 that are left, they have to do the work of 100. Then they get also, until they also kind of burn out and don't function, and then it gets lower and lower and lower. And that's and
that's where you have your failure already. When the remaining nephrons would say, we can't we can't take it anymore.
We can't lift this thing. There's only 2 of us left. And does it happen the same in both kidneys?
Yes.
So like, if let's say your right kidney, like 20 nephrons are down, and then your left kidney, is it also 20?
Actually, strictly speaking, it depends on the cause. No, for example, when you have a unilateral obstruction to one side of your urinary tract is blocked, then more the damage would likely be within that side. No, but if you have chronic or systemic conditions that affect both kidneys, then yes, both kidneys are affected.
Uniform, kind of.
Yes.
Okay.
Yes.
Doctor, what are before that, I want to ask you, before I ask you about the symptoms, what about cysts in the kidney? You know, cysts.
Sorry?
Like, cysts.
Cysts. Cysts. Okay.
You see, sometimes you will get an ultrasound or something, and they'll say, oh, you got cysts in your kidneys. It happens from 40 upwards, and it's just water, or ignore it. Doctors will say that. What do you think of that? Are they?
So sometimes, yes, they are generally asymptomatic and they get detected when you have a screening test for something else.
Mhm.
So the doctor says, "Oh, you have a cyst, go see a nephrologist." So there's a grading, or there's what you call this, a classification stage that we use, or for the risk of how you should follow it up. Basically, it's because of the risk for malignancy, if they're seemingly looking benign, or they have a tendency to be malignant. No, but if it's just a simple cyst with nothing in there, it's most likely just benign. And we usually just advise patients to follow up their ultrasound to monitor the size or the number. Okay. And if they don't really cause any problems like pain, or they're not that big, or they're not infected, we don't really take them out. So there's a specific type of disease called adult polycystic kidney disease, which is the ones that really cause CKD, but these are genetic or inherited disease of the kidney. So these cysts would grow large, even you'll have larger kidneys and with hundreds of cysts, and that would cause the kidney failure because the normal cells would get overwhelmed with the other cysts. Yes.
Okay.
But with simple cysts, we just observe.
Okay. Thank you, doctor. Okay. Now I don't know if I'm worried or not about someone else. No. Okay. Thanks, doc. Okay. So, what are the symptoms of chronic kidney disease? And how you end up diagnosing them? You mentioned a bit of that earlier, but you can go ahead and give us the whole kind of down on how it
Okay.
happens.
So, with symptoms, actually, well, early CKD may not have any symptoms. So it could be a result of screening, or incidental finding in some of the tests for some other condition, But some may have swelling, so especially in the dependent areas like the legs, or maybe in the face around the eyes, okay, or maybe changes in urination. Either too frequent urination, especially at night, or maybe too little urine, but this usually happens when you have advanced problems already, bubbly urine, that may be a sign of protein in the urine, or albuminuria, as we talked about, or changes in the color of the urine, But when you have advanced CKD, actually the symptoms are non-specific, So they can range for, let's say, subtle changes only, like I don't feel well, I feel tired, or I have trouble sleeping, I have fatigue, like that. So sometimes they're irritating symptoms, like it's very itchy all around me, but there's no rash, you don't have appetite, you have stomach aches, you have nausea, vomiting, like that. So sometimes the most severe manifestations maybe would be seizures, or maybe coma, or mental state changes, or if you have fluid overload already in your body, you can have shortness of breath, etc. So the symptoms and the signs are varied, can range from mild, moderate to the severe.
Okay, so some of the symptoms may be swelling that you'll see in the leg area, change in urination, either it's too frequent or not enough. But it also depends on a person's liquid intake. So
yes,
and then the other symptoms may be, bubbly urine, or but as you were saying, the most probably like a seizure and getting a seizure, something like that. That's already for something that's quite advanced, or
yes,
stomach aches, like they're non-specific. So if you are having doubts, or you already know you have a problem with your kidneys, then the best thing would be to get an EGFR and a urine test, and ask if you're not seeing a nephrologist yet, then maybe ask your doctor, should I see one?
Yes.
Okay.
And agree.
Okay. All right. So we're just gonna take a short break, Doc, and the audience out there, digest that. Don't freak out. We're here to help you. Healthline is a show where we don't treat you on the air because that's unethical. I mean, the doctor cannot like just, say, oh, you have this, you have that. You might have this, you might have that. But thank you to Makati Med and the wonderful doctors like you who come on the air with us and help inform and educate people who want to learn more and have a healthier lifestyle or just be uplifted. I mean, we do this show with a sense of positivity. We have compassion, we have empathy, but we do it with a sense of positivity and just getting information out there that can help everyone, no matter what state you're in. And if you're worried about a family member, well, then this is the show to watch. And you can always get in touch with the hospital or the doctors after the show. Okay, so we're just going to take a short break and we'll be right back.
You're listening to DZRJ 810 AM. We'll be right back after these reminders.
Hi, this is Dr. Jacinto from Makati Medical Center, and I'm happy to share that our world-class quality healthcare with the heart is now more accessible and affordable at Makati Med Care Access, Araneta City. What's more, Makati Med Care Access is the only single-use hemodialysis center in Araneta City. It's now easier for patients to avail of renal care services right in the heart of 𝗂𝗏𝗏. We offer health screening and diagnostic procedures in this facility at affordable rates. You can get services such as mammogram, ultrasound, lab procedures, ECG, and many others. We believe that access to affordable, quality, and compassionate healthcare is a basic human right. And we at Makati Med Care Access Araneta City are doing our best to make this possible to more people. You can find us at the ground floor of Manhattan Plaza Tower 1 in Araneta Center, 𝗂𝗏𝗏. We are open from Mondays to Saturdays from 7 a.m. to 5 p.m. and Sundays from 7 a.m. to 4 p.m. For inquiries, you may reach out to us at the numbers below. We look forward to serving you here at Makati Med Care Access, Araneta City.
You're back with Healthline, keeping you healthy, moderated by Nicole Jacinto.
Okay, welcome back to Healthline with Makati Med. I'm your host, Nicole Jacinto. We are here with Dr. 𝗂𝗏𝗏𝗏, a nephrologist from Makati Med. She practices in Makati Med, and we are talking about chronic kidney disease. And we've gone through a lot of like the functions of the kidney, what some of the parts, why this happens or how it happens. We've talked a little bit. She's described chronic kidney disease to us in a nutshell. And but can you tell us, Doc, about the stages of kidney disease once it's been diagnosed? Chronic kidney disease, sorry.
Chronic kidney disease, yes. So basically, staging of CKD entails at least two factors, Like we mentioned earlier about the GFR. So the level of your GFR is a factor, and the level of how much albumin you spill out in your urine.
Doctor,
okay, so yeah.
Can I ask you just about the GFR?
Sure.
When you get the eGFR or GFR, what is the scale? Like when you read it, let's say the result, is it like 1 to 100 or?
Okay. So actually what you initially get is your either creatinine, serum creatinine, or another test like cystatin C. But the nephrologist would usually compute the GFR for you. Because it would be better if you get guided, because not all creatinine measurements would, let's say, be stable enough for a GFR computation, because sometimes we might get a creatinine level that's fluctuating in wide ranges. So you have to have a a stable creatinine level first so that you can compute properly your GFR. So that's for in general, no? So, but when you have CKD, it's usually within a specific or a short range only. So, for example, when you have more than 90 or 90 ml per minute, or 90%, no, in layman's terms, you can have stage 1.
Okay.
And then
so it should be 100 or above 90 for you to say I'm not in
above. Sorry?
Or it should be above 90 or 100 in layman's terms percent for you to say I'm not in any stage. Once it's computed.
Once it's computed, so there's a scale, no, that we use. Let's say from above 90 and above, that's stage 1. 60 to less than 90 is that stage 2. Okay, so 45 to 30, or that's stage 3. Less than 30, from 15 to less than 30, that's stage 4, and less than 15, that's stage 5. So the severity of your kidney function is determined by GFR. And another one, albumin, no? Albuminuria, the amount of albumin that you pass out into, or protein that you passed out into your urine. So it depends on if you're, for example, you may have a lot of albumin in the urine, but be in stage, let's say 2 only, but that's still high risk, okay? Versus a person who has no albumin and moderately increased GFR, that's in a better place, no? So it depends on the combination of your albuminuria and your GFR category.
Okay, albuminuria and the GFR. So can I ask you something? If let's say you've gotten an EGFR test and then you get the results back, should you take it to a nephrologist to see if the computation is proper? Because who computes it in the lab? I mean,
yeah. So actually, sometimes even your primary physician can do it for you.
Okay.
Not necessarily a nephrologist. No. So there are actually calculators online available, and we use the 𝗂𝗶 equation to compute the GFR.
So albumin, not just albumin, because I see that all the time, but albuminurin, right?
Albuminuria, yeah.
Okay, let me
UACR.
Albuminuria. Okay.
Yeah, it just means albumin in the urine.
Okay, spell it. And
because it's different for the one in the serum albumin.
That's okay.
So it's specific for albumin in the urine, which if very high, that's abnormal, because it shouldn't be there, because albumin is such a big molecule that if it gets passed out into the urine, it means that your filter's not working properly, or if your filter's damaged because they're leaking out. Shouldn't be leaking out.
Okay. Thank you, doctor. I mean, that helps a lot with you telling us that it's not just the GFR test, but it's also the albuminuria. I got it right.
Yes, correct.
And that even our primary care physician can can tell us that, and there's a computation of stages. But as you were saying, well, if you're leaking out a lot of albuminuria, but your GFR seems to be okay, that's a bit problematic. So it has to be dealt with on a case-to-case basis.
Yes.
You don't have to freak out right away. Okay. Can chronic kidney disease be prevented?
Yes. That's why we do early screening, so that those at risk can control their risk factors and eventually, hopefully, prevent the development of CKD.
Okay, what are some of the risk factors for having CKD?
So aside from the ones that we already mentioned, having heart disease.
Yes.
Okay, so you can be at risk for CKD because that the heart is a major pumping organ of our body, so the blood flow to the kidneys is largely dependent on the function of the heart. Okay, other health conditions like maybe cancer, or major conditions like liver disease, etc., can have complications that may also put you at risk for CKD in the future. Okay. Repeated acute kidney injury, meaning repeated damages to the kidney in short courses, can be a risk factor for CKD. With a family history also, you can check your family. If you have family members who've had dialysis, for example, or kidney failure. So some kidney diseases tend to run within the family. So that may put you at risk for CKD. Exposures like to drugs, no, chemicals, heavy metals, no. So or as we said earlier, intake of painkillers, prolonged and recurrent, no, may put you at risk for CKD.
Doctor, what type of painkillers? Any kind of painkiller? Or
Generally NSAIDs, non-steroidal anti-inflammatory drugs. So mefenamic acid, ibuprofen. I'm careful not to say any brand names, but
okay. So, like ibuprofen. How about acetaminophen?
Paracetamol is relatively a safer alternative.
How about acetaminophen?
Yeah, that is similar to paracetamol.
Paracetamol, yeah, very
similar. Yeah, that is, yeah.
Okay, so those, we're trying not to say brand names. Those the painkillers, so the over-the-counter painkillers.
Over-the-counter painkillers, because especially when we have our lolos and lolas, diba, they have a lot of body aches, pains, no arthritis, and they just pop pills to make them feel better. So those with increased age, no, elderly, are at risk for CKD in the future. They are at risk for CKD because of not only because of the medications they take, no, but because they may have other conditions, no, comorbid conditions, no, that occur as well, no.
And did you see a demographic? Okay, we know that older people, as you mentioned, are could be more at risk. But do you seeing a lot, at least in your practice with the patients you've come across? Are you seeing more cases, and are you seeing? Go ahead.
Yeah, so not just patients who are in the older age group, no. Anyone can have CKD. Okay, so depending on the risk factors, because actually metabolic diseases, diabetes and hypertension don't really occur only in the older age groups, no. We are seeing increasing patients with, let's say, in your 30s or in your 40s that already have long-standing hypertension and diabetes. And obesity is also a risk factor for that. So the metabolic syndrome. So it's not unique to the elderly population. There are patients who are younger and have CKD too.
In my other work, which is not, in the medical field, I have seen a lot of people who have come to ask for help because of CKD, or because they basically need dialysis, which we'll talk a little bit more about later, like mechanisms or the types. And I came across this young woman. No, she was I didn't see her personally, but somebody asked help, so I passed it along to my boss. She was in her 20s. She had CKD, was stage 4, and then her parents passed away from it. And then the year after, she passed away from it too, even with the treatment. So, is that genetic, or
possible? Yes.
You can't give direct answers to that, but I was just shocked at how many. You seem to before this didn't exactly come up. Is it increasing, do you think, because of factors like?
There's increased awareness.
Increased awareness
of the disease, increased testing.
But it could have been all along.
Maybe yes, no.
Yeah. Yes.
Yeah, but actually there's a lot that has changed already with regards to our diet already, and our lifestyle. So when American diet or the eating out, etc.
Fast food,
fast food, yes, sedentary lifestyle. So all of that may play a role.
Yeah, play a role, and also, but as Filipinos, no, how about things like patis? I always heard patis is bad for your kidneys. Is that true?
Well, salty food in general.
Okay.
Yes.
And then, what about sodas? Which
Yes.
okay. Coffee? Now I'm asking for soda.
So if we're going to talk about like nutrition, if you are still normal, meaning you don't have CKD and you want to prevent CKD, so you might want to avoid too salty foods.
Yeah.
Avoid those that have too much preservatives. No, limit on your bad fats. Fats in the diet. No, so meaning you just need to take a healthy, balanced meal. No, yes, just control the added sugars, avoid junk food, no, in general. So
you're talking and I'm like, but no, it's true. We always hear these things, and now we have a doctor telling us, this can help. This can help you prevent it if you don't have the disease yet. And I'm so glad that you said a healthy, balanced diet, because sometimes when people think of dieting for health or for vanity or whatever it is, they go overboard, and then you think it's such a hard thing. But I think the times that I've tried, just small changes make a big difference, especially over time.
Yeah.
About hydration, because we're told drink water. How is that? Is that really good for the kidneys? Does it clear it up?
Yes, no. So it's not just diet and nutrition; it's also your fluid intake that can actually help protect your kidneys. No, so it depends on the climate. No, if it's very hot, of course, you need more than usual. No, it depends on how much you sweat, your activities, you exercise. No, so it's not one size fits all. Maybe you've read somewhere that you should take 8 to 10 glasses of water a day, and that will keep your kidneys healthy. Well, it's more of a myth, because it really depends on the person and the environment. No, so if it's a humid day, if it's a hot day, if it's a cool day, so it's very different when you say this one's your prescription for water for the day.
Yes.
There's really no prescription. No? It depends on your needs for that day.
And also, doctor, am I correct when in my belief that when it's colder, of course you're not gonna sweat, so you're gonna pee more? Okay, that's correct. So like, we also shouldn't freak out when we're like, oh my God, like if you're in an air conditioned room the whole day, then
yes, or sometimes when you've taken like coffee, after a while you want to pee. So
you shouldn't be like, oh my God, do I have CKD because I'm peeing more often? It depends on the days. I'm glad you said that, like what you did during the day. And baka naman you had 10 glasses of water during dinner. The food so that's why you were peeing the whole night. Because I do have friends who freak out a little bit sometimes, or they start thinking about it too much. And I'm like, the show is here to help you. That's why I ask these like frequent, like sort of questions, just to clear it up. You're so, you're so game, and you're so onto it that you're giving us pretty much all the information we need. Okay. We are just gonna take a short break, doctor, and I'll ask you how what the treatment is exactly for chronic kidney disease. So everybody stay tuned. There's more to come, and we'll be right back.
Double R is now at Radio Bandido, an informative program that tackles all issues concerning all walks of life, delivering hottest issues and events, with health consultations on air and a lot more, with your host veteran newsman Ricky Sunga and master entrepreneur Ruel So. Double R sa Radio Bandido every Saturday from 10 to 11 a.m. You can catch Double R on DZRJ 8:10 a.m., Radio Bandido TV channel 224, TV Plus boxes, and streaming live on Facebook/DZRJ 8:10 a.m. and YouTube channel DZRJ 8:10 a.m. Radio Bandido. Welcome the newest addition to our lineup of explosive anchors. A veteran broadcaster, a sports news anchor, race car driver, columnist, and reporter. 𝗂𝗏𝗶𝗵𝗹 and his program Free Spits. Free Spits, a parody of free speech, a right we always abuse. Free Spits, freewheeling discussions, no holds barred. Free Spits, the real sentiments of the Filipino people. Free Spits and 𝗂𝗏𝗶𝗵, Monday to Friday from 5 to 6:30 p.m. on Radio Bandido TV, Channel 224 Sky Cable, TV Plus boxes, GMA Affordable box, and all DTT boxes. Also heard on DZRJ 8:10 a.m. Also seen on Facebook/DZRJ 8:10 a.m. and YouTube channel DZRJ 8:10 a.m. Radio Bandido. Bangon na! Tanghali na! RJ na! Sally Masa, with host Sunny Ilustre, digs into current events and human interests. All viewers and listeners are invited to take part in the discussion. All opinions are welcome and respected. Sally Masa is open to assist those experiencing injustice. The motto of the show is, "If God is with us, who is against us?" Seen every Saturday from 4 to 5 p.m. on Radio Bandido TV, Channel 224 Sky Cable, TV Plus boxes, digital free-to-air channel 29, facebook.com/DZRJ 8:10 a.m. or on YouTube, channel DZRJ 8:10 a.m. Radio Bandido.
Serbisyo publiko ba ang hanap mo? Programang tutulong at aalalay sa iyo. Tuwing linggo, Carmen Ignacio, Mark Anthony Ignacio, Miss Teresita Amansek, Malasaki Kapwa. 2 oras ng aksyon, ng tulong, ng puso. Malasakit Kapwa. 1:00 hanggang 3:00 ng hapon. Malasakit Kapwa. Mapapanood at mapakikinggan sa DZRJ 8:10 a.m. sa Radyo Bandido TV, TV Plus boxes, Sky Cable Channel 224, Digital Free-to-Air Channel 29, Facebook.com/DZRJ 8:10 a.m. at sa YouTube channel
DZRJ 8:10 a.m. Radio Bandido.
Malasakit Kapwa. Aksyon, tulong, puso. Malasakit Kapwa.
Good News Pilipinas with host Francis de Guzman is advocacy in action, which brings to you exclusives to enhance life's values that really matter. This program also brings forth guideposts on scriptural truths, giving hope to nations. Watch and listen on Radio Bandido TV every Sunday from 12 noon to 1 p.m. on Channel 224 Sky Cable, TV Plus boxes, digital free-to-air Channel 29, DZRJ 8:10 a.m., Facebook.com/DZRJ 8:10 a.m. and YouTube channel DZRJ 8:10 a.m. Radio Bandido. Join Arnel Doria as he explores the world of travel, transportation, road safety, and the environment. Tune in to Good Trip every Saturday at 1 to 2 p.m. on Radio Bandido TV, Channel 224 Sky Cable, TV Plus boxes, digital free-to-air Channel 29, Facebook.com/DZRJ 8:10 a.m. and YouTube channel DZRJ 8:10 a.m. Radio Bandido. Fierce, fast, and on the go. Reporters Hour, hosted by 𝗂𝗏𝗏𝗵𝗹. Meet the fearless reporters of Teleradio Bandido TV, Celestino Jojo Sicat, Vance Fernandez, Jong Manlapas, Jimmy Mahusay, Felix Tambongco, and Romel Madrigal. During a crisis, you need timely and up-to-date reports on Radio Bandido TV, daily, plus on Reporters Hour, 12 noon to 1 p.m. except Tuesdays on Channel 224 Sky Cable, TV Plus boxes, digital free-to-air Channel 29, DZRJ 8:10 a.m., Facebook.com/DZRJ 8:10 a.m., and on YouTube, Channel DZRJ 8:10 a.m., Radio Bandido. Chit Chat with Double V with host Vivian Velez is a program that breaks down important national concerns, events, and stories, featuring newsmaker interviews and compelling features to add context, clarity, and answer the questions on your mind. Every Sundays from 5 p.m. to 6:30 p.m. on Radio Bandido TV, Channel 224 Sky Cable, TV Plus boxes, GMA Affordable Box, Easy Box, and all DTT boxes. Simulcast on DZRJ 8:10 a.m. Seen on Facebook/DZRJ 8:10 a.m. and YouTube channel DZRJ 8:10 a.m. Radio Bandido. 𝗂𝗶𝗵𝗶 is a news-oriented program that tackles topical issues and headlines with the support of DZRJ field reporters. Hosted by the legendary Jimmy Morato, Monday to Friday from 4 p.m. to 5 p.m. on Radio Bandido TV, Channel 224 Sky Cable, TV Plus boxes, digital free-to-air Channel 29, DZRJ 8:10 a.m., Facebook.com/DZRJ 8:10 a.m., and on YouTube channel DZRJ 8:10 a.m. Radio Bandido.
You're back with Healthline, keeping you healthy. Moderated by Nicole Jacinto.
Doctor, welcome back to Healthline with Makati Med. Doctor, you're still here. I'm welcoming you anyway. My name is Nicole Jacinto. I'm your host. We're here with Dr. 𝗂𝗛𝗹𝗁, and she's a nephrologist. We've been talking about chronic kidney disease and a lot of other things that have come into play when it comes to the kidneys. Doctor, can I ask you, what is a treatment for chronic kidney disease?
Okay, so generally it depends on the stage of your CKD, no? But if ever you get to the stage wherein your kidneys really need the help, no, you can be offered different types of treatment like dialysis or transplantation. This is usually for those who have very advanced CKD and are in quote unquote end stage kidney disease. So there are two types of dialysis treatment. So that's hemodialysis, the one that uses a machine, and peritoneal dialysis. And this uses your own body, you know, to be sort of a filter, you know, to rid of the wastes. And another one is kidney transplantation. So these are the different types of renal replacement therapies when you get to the stage of CKD that you may need them. So the best, of course, if you ask me, is still transplant. If you get a new set of nephrons, then that would be great. A new set of nephrons, a new kidney.
May I ask?
Yeah.
Sorry, doctor. May I ask you to tell us more about, to go through the stages of like dialysis, or talk more about the two. Hemodialysis, that would, I guess, from hemo blood.
Blood, yes.
So how does that work exactly in a setting so that members of our audience don't imagine it as this like big abstract thing, and they know kind of what to expect and they can stay calmer about it?
Okay, so we said earlier, no, that the kidneys function like a filter. So we need an artificial filter to do the job for the kidneys, no? So, but of course, it can't do the 100% work that the kidneys really do, no? So, for the hemodialysis, it would be a dialyzer. So, you would need an access, like either a fistula, an AV graft, or maybe a temporary catheter to draw out the blood, no? Draw out the blood from your body, not the whole of it, a part of it only.
Yes.
And then it goes through, circulates through that
Machine.
that filter, that machine, no? So the dialyzer gets rid of the wastes, and then the clean blood gets returned to your body in the same access.
And the access point, is it usually in the arm, on the back, or
yes, it can be the ones that are preferred are the ones which we call AV fistula or arteriovenous fistula, usually in the arm.
Okay, in the arm.
So, but you can have some patients who would like say have emergency dialysis because they don't have yet a working fistula or a working arm access, would need a temporary catheter, maybe inserted around the neck area, on the neck area, or in the groin area.
Or are these once when you do the work, okay, because there are people I've met who have dialysis, who have hemodialysis like 3 times a week. Is it an open thing, an open wound? Like I didn't look at their body.
No. So if you're talking about the fistula or an EV fistula, it's just actually a part of your body, blood vessels that were joined together to be bigger and stronger, to handle the pressures that the machine need. So it's not an open wound, but you need needles to access the blood vessel.
So parang you're just it's kind of just getting like a procedure, like putting an IV in, sort of.
Correct. Yes.
Okay. So
or maybe like getting a blood transfusion.
Yes, getting a blood transfusion. Yes.
Yes. But the difference is the blood gets, or donating blood, maybe. When you donate blood, diba, the blood gets out of your body, but it circulates through the machine, through the dialyzer, and then gets returned. The clean blood gets returned to your body and through the same access.
Very specific, doctor. Earlier you said when you said that, I heard you mention that it can't do all of the work. Well, obviously, because you did say that the kidneys release hormones, so it can clean in the waste, but it can't put hormones.
Yes, it's not a perfect solution. No, it's not a cure. It's just a treatment. So it can't supply the hormones that the normal kidneys would normally, release.
You're so thorough. I really like it. I mean, nobody ever wants to say, I want to see you as a nephrologist, but I hope you don't mind if I give you a call and
no problem.
Somebody that was very special to me, or a friend to you later on. And then, okay, the other type of dialysis you were saying, which is just body. That's very interesting. That's the first time I've heard.
Yes, amazing, right? So,
yes. Can you tell us about it? Because when we hear dialysis, all we think of is the machine, no?
Correct. So also in Makati Med, we have a very good PD unit, headed by our head, Dr. 𝗛𝗶𝗵𝗶. So our bodies, in our abdomen, there's a lining called the peritoneum. Within our abdomen, there's a lining there. And that is the filter that can substitute for your kidneys. Okay, so it usually uses solutions or peritoneal dialysis solutions that get infused into your abdomen, and then you leave
that area.
Actually, you would also need a catheter, a peritoneal dialysis catheter, inserted into the abdomen, and the dialysis solution would be infused through there. It gets left inside your belly for a few hours, and then the peritoneum does the work. So it filters out the wastes, and then when you drain your abdomen, it comes out as already your sort of parang urine. It's similar to the urine already.
How do you drain it
through the catheter also? So there's a mechanism wherein we can infuse the fluid, and then later on, after dwelling within the abdomen, you can drain it through the same tubings, and it gets stored in the bags, the peritoneal dialysis bags, and then you can dispose of it like in the toilet, as like urine also.
And you have to stay in the.
You can do it in the house.
Oh, you can do it in the house. Okay.
You can do it at home, so you can do it maybe on your own or with an able partner, and that's different from hemodialysis, wherein hemodialysis you do it in a center. So they're amazing.
How long does it take for dialysis? Sorry, just quick questions. Usually
for hemodialysis, about 3 to 4 hours per session. Okay, but usually 4 hours in the Philippines, about 3 times a week.
Yeah.
Okay. For peritoneal dialysis, you'd have to do it every day. About maybe 3 to 6 exchanges, depending on your prescription. But
new method, doctor, or
no,
around for a while. We just
been around for a while.
Much. It's been around for a while. Okay. Do you find that patients prefer one over the other?
Yes. So some patients who are not comfortable going to the dialysis unit, especially during the pandemic, or can do or can train for PD, would prefer PD because they would have more time on their own hands, so they can do PD while at work, or when they get home during lunch break, before they sleep, etc. Or some patients naman don't want to do the work on their own, so they just want to go to a center and then have the dialysis, and after that, that's it. It depends on the preference, and of course the medical assessment of your nephrologist, whether you're fit for hemodialysis or peritoneal dialysis. So it's a viable option. PD is also a viable option, and we actually advocate that patients should or would want to explore PD first before trying out hemodialysis.
Yes, I see. I'd never heard of that, and I talked to so many people who are on dialysis. They'd never mentioned it. May I ask you, doctor, also? Okay, before we go into the kidney transplant, because I know that's important. What color should your urine be? In general, if it's healthy, if it's not, and do you see when you do dialysis? I've always wondered, do people on dialysis, do they still pee?
Some of them, yes. Some of them, yes. The others, unfortunately, they don't anymore. But some of them can still have some urine output, but not as much as normal persons.
Because it's been done already for them.
Yes. So with regards to the color, it depends on how much you drank for the day, or fluid intake, or if you slept for hours without peeing, your urine the next day might be a little concentrated already, so more yellow than usual. So it depends on your fluid intake. The color of urine depends on your water intake.
If you're drinking coffee the whole day, and then
it won't turn to be coffee colored, but
yes, that would be what? No, but it will be like darker.
If you don't take a lot of water with coffee, it might get dark.
Okay. Ding. Okay. All right. So we have reserved a bit of time for as you mentioned, the kidney transplant. Can you tell us about it? In terms of, okay, when do you determine someone needs a kidney transplant? Or as you said, you would recommend that, no? How does one screen for it? When do you determine that somebody needs one, or when do you suggest it? How does one screen for it? What is the age usually?
So in general, any CKD patient on dialysis, or those who have creatinine clearance of less than 20, even if they're not yet on dialysis, may be eligible for a kidney transplant. So it depends on your medical condition, and your risk factors or suitability for transplantation, because you may have other conditions, like say a severe ischemic heart disease that may need first to be controlled before you undergo transplantation, because transplantation is it's an operation, no? It's a surgical procedure. Yes. So if you have active infections, you have to control first your active infections. An active malignancy, no? If you have an active malignancy, it has to be controlled first, or the tumor has to be out first. So there's a lot of screening and suitability testing before undergoing transplantation. So not just medically speaking, but mentally and psychologically speaking as well. So
do you
yes,
work with a team, and like maybe if someone
yes,
needs a psychologist or a psychiatrist, do you like recommend that? Because a lot of people need,
yes,
you know.
because actually transplant may be easy at the start, but you have to take medicines long term, and you have to be compliant with your follow-ups and your checkups. So the history of good compliance is actually a prerequisite.
Yes.
Or you'd want to have a patient who would be following up and taking medications. Otherwise, if you have a patient who is not really good with compliance or medications, the transplant later on might fail. So there's a team that manages this, and we call it a transplant team. So it could consist with your nephrologist, your surgeon, your nurse, your coordinator, psychiatrist, your educator, a lot of people involved in the care of a renal patient. No, so there's a lot involved.
I will say something that maybe on some of the members of the audience's mind. You said there's a lot of compliance involved, and you want a patient, of course, who will take care of themselves, because you don't want the transplant, like after all of this, for it to fail because they were just, kind of flippant, callous with their. So I will say what's on the mind of some of the audience members, maybe myself. Don't waste the new kidney. Give it to someone who needs it. I mean, because I've met people that they have had kidney transplants, but they're like, ooh, drinking up a storm. And I'm like, I don't know, does your doctor know that? But then they don't want to, interfere. But sometimes it's just being very candid and open. It's like, gosh, man, maybe somebody else could have used that healthy kidney that was given to you if you really don't care and you're just going to throw it all away. I know it's on some people's minds right now who are watching me, some of my friends. So anyway, I just had to put that out there because you're a doctor, you're much too kind to say that, but I'm a host and I can sort of say these things. All right, doctor. When it comes to the transplant, what makes you eligible? Like, okay, how do you find a match? Does it just your blood type or size of the kidney? Sort of thing, like how would you find the match for a transplant, kidney transplant?
Yes, so you should have a donor first, no? So your donor could be someone related to you, okay? May not be related. It's better for the donor to be related to you, but the donor may not be related to you. Could be just someone emotionally attached to you, or maybe someone whom you've had a relationship with and is willing to give a kidney for you. So
you can be like to your ex, hey, you did me wrong, give me one of your kidneys now. Emotional attachment.
Yeah, but of course the donor has to be healthy.
Yes.
Okay, because if the donor has some risk factors also for kidney disease, you wouldn't want to take one kidney from that person.
And the donor will be the one.
Yes. So it's not just the recipient that gets screened. It's also the donors also have an evaluation on their own.
And do they need to have the same blood type? Well,
ideally it would be better, but there are already advancements in medicine wherein you can have ABO incompatibility transplants. So they do some medications or procedures and before transplantation to desensitize you for you to be able to receive the new kidney, even if you're not a complete match. So and
Complete
so.
match. And then
Yes.
does the size matter of the kidney?
Yes. Yes. Well, if you have a small donor size kidney, it might not be as good as a normal sized kidney. But if there's no other
Yeah.
no
And then
other
it's better than
option,
nothing. Yeah.
so it's just important for it to be also viable. So if you're small also, then a similar sized person with a small kidney, same as yours, would be okay, as long as it is still working and viable.
Yes, thank you. I just imagine, like, a bigger kidney being put into a very small frame, like a child or a teenager, getting a
we don't get I have to say this, we don't get kidneys from children to be transplanted into adults. No.
How about kidneys from adults be transplanted into children?
Possible, yeah.
Possible, okay. But the size
Size.
Okay. All right. And then you were talking about people, you want patients who follow up, after. What are some of the things that they have to follow up on once they've had a kidney transplant? Just to have an idea.
Yes. So a lot of things, after transplantation, of course, the function of your new kidney will get evaluated, and also your risk for infections, because you're going to be on immunosuppressants. So these are medications that might dampen your immune system, and you might that you take orally, and it may be risk factor for certain infections. So you also are monitored for that. So drug levels have to be also monitored, to avoid toxicity. So compliance to the medications also have to be monitored. So a lot of things, and the usual, your blood pressure, your other conditions, So there.
But you're getting a new lease on life, so of course you want someone who will do all the follow-ups, and well, that's the concentrating on getting better and healing yourself, and maybe family members or caretakers or caregivers who can help with that. I mean, when I say caregivers, it's not just people who so generously go into the field and help us as people whom you pay, but I mean also people within the family or friends who who attend to a person who's sick and bring them up, help them through the process. Okay, so doctor, do you have any sorry, so sorry, I kind of got lost in my thought about that. How long usually does it take for the compliance period?
Oh, you have to take the medications for the rest of your life.
Okay.
Yes.
And is there a time? How long is the time when you kind of have to be monitoring yourself, like going to the doctor regularly after the?
Okay. So maybe soon after transplantation, it's more frequent. Okay, and then later on, when your graft function is stable, then it could be with longer time in between follow-ups.
Okay. So the doctor and the transplant team, as you call them, will tell you, okay, we need you here right now, and then maybe in 6 months come back, and then
or maybe monthly first for the first few months, and then later on, just after a few years of being stable, you can do annual checkups.
And have you seen a lot of successful transplants with the patients you've had? I mean, of course, without revealing identities or just in your experience that you've come across, maybe you've not treated them, it's others, but you've been part of the team or a consultant on it. Have you seen a lot of I guess, when do you see the most successful transplants? Is there a demographic? Is there an age? Is there anything to it? Any kind of common factor?
Well, success in transplants depend on a lot of things, no, medical, surgical, no, etc. But success really, from the person's perspective, no, it's greatly improve their quality of life. So being off dialysis, that's a really big burden out of the patients. So that in itself is a huge success already for the transplant team, no, to be able to give that patient a chance to live normally, no, without being hooked to a machine or being on dialysis for the rest of their life. So the best care would depend on, of course, patient compliance and adequate follow-up, no? Yeah.
Okay. You were saying earlier in terms of choosing the donor, it's better if it's someone you're related to or someone who has an emotional attachment to you. But you can also from a stranger. Okay, sige, go ahead.
Yeah, but actually you can have, there's a thing called cadaveric donor. So they're not living kidney donors. And there's a wait list for that. But of course, the list is very, very long. Yes. So if you don't have a person or a family member or a friend who would be donating a kidney to you, you can still have a chance at transplant by being on the waiting list for cadaveric donor.
But you can have a friend who can donate a kidney to you.
Yes.
You want to donate. Okay, I see. Okay. And then there's a wait list, of course, for transplants from, I guess, when you say cadaveric organ donors, like they have no brain function, but...
Yes.
Okay.
Yes.
Okay, they have no brain function, and then they...
So these are the ones who have signed their I'm a donor, I'm an organ donor card, or who have been in the hospital for some other thing, like usually traumatic brain injury, you know, but the kidneys are fine and the body is healthy. So they get tested for infections, etc. And if the kidneys are viable enough to be transplanted to another person, then it goes to the person on the waiting list.
Okay. I'm not going to ask a very controversial question. Don't worry. I'm not going to go there. Because I know it's more like, it's really difficult. We're trying to, with this show, we're trying to promote people to take care of their kidneys. I mean, trying to get the information out there. And, anyway, I know minds are going there, like, so but basta you can get a friend to give you a kidney.
Yes, if they're willing.
If they're willing. Yes, if they're willing.
And they are mentally healthy, meaning they did it on their own decision, no, because they want to help you without being forced to do it or without being paid to do it, then that is being that's also a possible transplant donor for you.
Thank you for addressing it. Thank you for addressing the question that was difficult to ask without, trying to stir up any controversy. Okay. Just very quickly, how is a transplant performed? How long does it take?
So a transplant is performed in the operating room. So you harvest the kidney from the donor, and then it gets stored in the cold, bathed in ice, before it gets transplanted to your body. So you don't actually take out your two other kidneys. No, it's just so you technically have 3 kidneys there.
Yeah, and you attach it na lang. Okay.
Attach it there. And then after a few hours, maybe you can see already that the signs that your kidneys or your new kidney may be working, no? Yeah.
Go ahead, doctor.
Yeah. So it's an inpatient procedure. It's an operation, and then you can have your recovery period, for a few more days, and then after a few days, let's say 3 or 5 days, you get discharged.
And
if without complications.
okay. And as a donor, is the donor in the same room? You know, like how we see
No,
that dramatic thing where the donor is there. No,
it's in
okay.
a different room, no, but
Okay.
the kidney will be transported to your
With
OR
the,
suite, yeah,
with the ice.
with
With,
ice,
on the
yes.
rocks. Kidney on the
On
rocks.
the rocks,
Okay,
yes.
on the rocks. Okay. Okay. So doctor, are there any is there anything you'd like to say about chronic kidney disease or renal care in general? Is there anything you'd like to impart to the audience as a nephrologist or yes, as a nephrologist or someone who's focusing on either chronic kidney disease or just simply renal care?
So actually, there's a lot of information, no, everywhere, no, even on the internet, everything's out there. But it's very important to filter out the facts from the fakes, no. So if we're fond of reading things in social media, no, we have to be wary. Okay, there's a lot there offering cure-alls for CKDs, no, that might lead to more harm than good. So it's really best to seek guidance and talk to your physician regarding maybe the steps on how to address your risk factors for CKD. No? So while we've already talked about the general approaches here, no, for education purposes, the actual management of each patient is well individualized, no, based on your goals, your characteristics, your environment, no, your situation, no, your comorbid conditions, of course, what the cause of your disease, your etiology, your complications, and your disease progression. So it's very important to have a partner in the care of a patient with CKD. No? So it's usually handled by a multidisciplinary team, and it's best to consult early if you have CKD so that treatment and treatment can be started and you can be monitored more closely.
Thank you, doctor. So basically, just to kind of add a little bit to what you said, as some parting words for this episode, if you can get it early, so basically monitor yourself if you know you're at risk, get the test done, work with the doctor, and then if you're referred to a nephrologist like yourself, then that's when the work starts and the approach. And as you said, it's individualized. It's not just like blanket, like one size fits all. And then you'll see how you can handle it. And you did mention the patient should have a good partner in that, because there are mental health issues that can come about or will come about from this difficult disease. Doctor, I want to thank you so much for being on the show. And I want to thank you so much for being game about answering the questions and getting it, because there are some things that some people really want me to ask. And
I hope we've made it simple enough for everyone to understand, because
I think I think your intelligence shines through, and yet it's simple enough for people to understand. It's straightforward. Thank you so much for being on the show. And
thank you also.
If I can call you afterwards and ask for your clinic hours. So yes or no? Okay.
Sure.
No, okay, sure. Okay, put you on the spot. Thank you so much, doctor. And this was very educational for me, and I'm sure for a lot of people out there. And again, is there anyone you'd like to greet before we say bye?
I'd like to say hello to everyone in the section of nephrology at Makati Medical Center.
Okay, I'd like to say hello to them too. And God bless you guys and what you do for people. Okay, thank you, doctor. And thank you to the audience for staying tuned. I'm sure this is an episode that will probably be watched and rewatched by a lot of people. Thank you, Dr. Azaita.
Thank you.
Okay. Bye, guys. Come back. Stay tuned next week. Come back next week for Healthline with Makati Med.
Thank you for tuning in to Healthline with expert doctors from Makati Med, giving you the chance to interact, uplifting your lifestyle. Moderated by Nicole Jacinto. Tune in again next week for your weekly dose of Healthline.